We are so excited to have you join us tonight for our Dermalorian webinar. This is a special series, the Itch and Rash Whisperer Virtual Grand Rounds. We're very lucky to have us join this evening by our esteemed faculty that are going to introduce this series and walk us through the essence of itch and rash and how we can bring better results to our patients, but also how we can be better in terms of providers. First, I'd like to introduce Dr. Jenny Murase, who comes to us as the Associate Clinical Professor of Dermatology at the University of California in San Francisco. She's the Director of Medical Consultative Dermatology and Patch Testing at Palo Alto Medical Foundation here in Mountain View, California. And we could not be luckier to have with us also the nurse practitioner in her office, April Martinez-Dulay. So excited to have you both with us for this first novel, groundbreaking Dermalorian webinar, the Itch and Rash Whisperer Virtual Grand Rounds.
Thank you so much for having us, Joe.
We're
very excited.
And thank you. And none of this will be possible without the generous support of our industry sponsors. We want to say a loud and enthusiastic thanks to AbbVie and Sanofi and Regeneron. So Dr. Murase and April, we're going to hand it over to you to help run us through the program. Your disclosures are listed here for everyone to see. And thank you for this great presentation.
We're so grateful to the DEF for supporting something so important in terms of itch and rash. Why we're called the rash whisperers is that we kind of take any uncontrolled, untamed rash in the Bay Area and get it under control. And this is a picture of me fighting with April's husband, Mayrick. And who won this tug of war, April?
So if you think that this masculine man on the right side won, then you're wrong, because the Wonder Woman on my left side won in that tug of war.
Yes, indeed. We have been work wives for 14 years now, taking care of the itchiest, rashiest patients of the Bay Area. And we've done about 7,000 consults together over many years. And why did you decide to help me take care of these very difficult to manage patients?
So that's a great question. And decided you are my work wife because I spent 10 hours with you in the clinic and 3 hours with my husband, is that not everyone has an opportunity to take care of the most vulnerable patients in the Bay Area, for the patients who are incessantly itching and having recalcitrant dermatitis.
So we're really grateful for all of you tonight to log in and learn more about how to care for itch and rash, because I really feel, I know April feels the same, that these are patients are in the end the most grateful for caring for them because they're really suffering. And I think one of the things that we struggle with as dermatology providers is that we'll go in and none of the patients read the textbooks. They might have a little bit of urticaria, they might have a few, edematous papules and eczematous plaques, and we never know what chapter to go to in our books in caring for patients. And so what April and I tried to do was take what we've seen in these 7,000 consults and distill it into information that you can use so that you can get through the visits very quickly and efficiently, and then also get the patients the answers that they need so that you know how to order the right diagnostics and therapeutics, and also give a lot of counseling tips on how to counsel your patients. And so our goals for these first two webinars, so this is the inaugural webinar today, we're going to be really focused on the physical exams and the basic forms of rashes that we would see, talking about how we describe the morphology, how to sort of talk like a dermatologist. And then in the second webinar, we'll also review some basics in terms of the immune mechanism as well as history taking, and focus on the key elements of the intake, and talk about our most important therapeutic pearl. And then in the subsequent webinars, what we're going to do is we're going to take different case presentation subtypes now that we have those two webinars for the background, and we'll talk about how to address things like a steroid withdrawal patient with with terrible eczematous dermatitis, or cases of subacute prurigo, or this id hypersensitivity reactions, acne that's not acne, psoriasis that's not psoriasis, a chronic itch with minimal skin findings. And all of these different subtypes, we're going to review the best diagnostic and therapeutic strategy, but we're going to start with the basics first. So that is the essence of what we use day in, day out, right? So first, April, do you want to describe the difference between a type 1 and a type 4 reaction and how we would evaluate and explain it to the patient?
The way that we can explain it to the patient in a term is that the type 1 versus type 4 is that type 1 is immediate. So within 15 minutes, you get that reaction. Type 4 is a delayed, most likely 48 hours to 72 hours or later time. And it's the type 1 is driven by the mast cells, and the type 4 is driven by the T cells or eczema or dermatitis. I think Dr. Russell want to add on to that.
Yeah, so the mast cells are almost like firecrackers. They're covered in these histamine packets, and then they explode and release histamine, and then the patient, they become very twitchy. And so the tests that are done for this are really not particularly that helpful in general. Sometimes people will experience hives by rolling around in grass, and they'll develop a hive reaction or something. But there's really limited they're limited in how helpful they are to order prick testing or RAS testing, whereas the patch testing for an eczema, where the T cells are present and they've been for a long time, that can be really helpful. So what are the categories you think of in terms of skincare products that can have things that can trigger rashes?
Well, the most common one is fragrances, surfactants, which is things that bubbles like soaps, shampoos. Emulsifiers are also common in like cosmetic products and other personal products, and preservatives.
Yeah, the emulsifiers are like the wool alcohol that would provide the oil to water feel to the product. And sometimes the patients can even be allergic to the topical medicines. And so we'll talk about that. It's tricky to figure that allergy out. So there are most rashes, and we'll talk about this particularly in the second webinar, but just to briefly touch on this first webinar, because it's just so important. We're always whipping out the paper in clinic, and then we're writing our yin yang and explaining it to the patient with our yin yang that we quickly draw. So the T cells, there is we draw a yin yang where there's Th1 and Th17 kind of on one side, and then Th2 on the other. So the Th1 is like the soldiers of the immune system. So they're going to fight, bacteria, fungus, and virus. So that's the intracellular pathogens. The regulatory T cells also address the extracellular pathogens, and IL-17 would be an example of an interleukin that's involved. Whereas the type 2, the allergic arm of the immune system, that's driven by interleukins like IL-4, IL-13, IL-31, for example. And so we cause a shift in immunity based on the different therapeutics that we select. And so this yin-yang concept we're going to be using when we're talking about different rashes as well as therapeutic strategy. So what's the difference? So we have a type 1 versus type 4, and some people can be mixed picture, right?
Right.
But what are you thinking, and how do you evaluate for type 1 versus type 4?
So for the type 1, is the urticarial plaques for patients come in, just grab a wooden stick,
Like the
or
tongue blade?
the tongue blade that's available in the clinic. You mark an X on the patient's skin, and if that skin welts up, then it means that this patient is full load of mast cells. And the way to treat this is that we give them antihistamines for at least minimum of at least 3 months.
Yeah. So it's pretty easy to look for the dermatography, and it's really helpful clinically because you need to prescribe antihistamines or recommend antihistamines as well as other therapeutics we'll talk about. Whereas a dermatitis, what do you think about a dermatitis when you're looking?
We're looking into a rash that are edematous, or there's like an inflammation, and an eczematous for the eczematous dermatitis,
where the skin barrier is compromised, not just swollen up, but compromised. And these are going to last for days, weeks, months, depending. And so those are two terms that we regularly use when we're describing rashes. And those will be treated with things like topical or oral steroids or other immunomodulators. And here's that X marks the spot that April was just talking about. So we do that on the back, especially if there's minimal skin findings, because they can be itchy without minimal skin findings. And we know we need to make sure we're addressing those mast cells. Another way to approach a rash is to try to figure out which bucket to put the rash into. We have our very, very large eczematous bucket, right? We see those all the time in clinic. And then we have the smaller papulosquamous bucket. So the papulosquamous bucket classically would be things like psoriasis or lichen planus or even cutaneous lupus. What about our eczematous bucket?
Oh, we have a bunch. So
lot.
number one is our favorite, which is atopic dermatitis, the genetic eczema. We do have the allergic contact dermatitis, which can be ruled out via patch testing. And the irritant contact dermatitis is very common for patients, for example, who frequently washing their hands, tripping up the oil on the skin and exposure to the soaps. Seborrheic dermatitis is very common also. It's just that basically an overproduction of the normal yeast in our skin, common on the scalp, sides of the nose, eyebrows. The nubular dermatitis is like the annular type of dermatitis, like a circle. The asiatotic eczema, very common, eczema on the lower legs or in the legs. I just saw a stasis dermatitis case today. So it's just like there's like a inclusion of like poor circulation on the legs. So there's always the examples of eczematous buckets.
Yeah, yeah. And sometimes the diagnoses are based on morphology, meaning the shape that you see on the skin. So when you say somebody has a nummular dermatitis, all you're saying is that there are coin-shaped plaques on their body. That's it. If they have stasis dermatitis, the implication is that because of water building up from, as April was saying, the poor venous circulation, then the leg swelling. Atopic dermatitis, that's based on etiology. In other words, they have a genetic predisposition to develop dermatitis. So sometimes we'll use morphology, sometimes we'll use etiology. And so patients can get confused when they hear that, do I have irritant contact, allergic contact, atopic dermatitis? And sometimes the answer is yes, yes, and yes, because we're the kings and queens of the multifactorial diagnosis in dermatology. So the way that we distinguish between eczematous process and a papulosquamous is by the biopsy. And when a patient comes in and says, oh, the provider biopsied the rash, but it didn't say anything, that gives me a slight heart attack. The biopsy always shows something. And so you need to be able to communicate what the biopsy showed to the patient so they have an understanding of what it caused. So the spongiotic dermatitis is when the cells of that top layer of the skin, the epidermis, they swell up like a sponge. So we call that a spongiotic dermatitis. And there may be eosinophils or allergy cells, but most importantly, the skin barrier is compromised. Whereas if you have a papulosquamous dermatitis, under the microscope, the epidermis will be thickened, but the skin barrier is not compromised. So which one is more likely to be infected?
Well, absolutely. The skin barrier is compromised, which is on the eczematous buckets.
Yes, for the spongiotic dermatitis. And staph loves to jump in that back door, the Staphylococcus aureus. They can get the viral infections that we'll talk about, as well as fungal infections. Okay, so now we're going to learn how to talk like a dermatologist. Because when I was in medical school, everyone would say, oh, just say it's a maculopapular rash, because they didn't know how to describe it. So
Yeah.
we're gonna talk about how to describe rashes and talk about what is really important to look for when you're looking for a rash so that you can really help that patient. So what's the difference between the macules, papules, patches, and plaques?
So the just remember the macula and a patch, flat, no, non-palpable. Papule and plaques are palpable, which is raised. So papule and plaques are raised, macula and patch are flat. Macula and papule, based on the size, less than 1 centimeter. And if they're more than 1 centimeter, that will be a patch and plaques.
Okay, so we're going to talk about the scale, the distribution, and locations on the body. So we just talked about an edematous versus an eczematous plaque or papule. And then also sometimes they can be targetoid, and there are many fewer rashes that have a targetoid look. So if you do see things that look like targets, that's really important to point out and also to biopsy often. And then what is the difference between annular and serpiginous and geographic?
So from the word annular, circular, so it's going to be a ring-like. If you see this picture right here on the very first, and most important to remember to do a diagnostics, making sure that it's not a tinea, because this is one of the differentials that you would do with the antler ring-like. The serpiginous is just remember wave. So that's the upcoming DEF wave. And
Wavy line.
the wavy line, and then the geographic is like a map, as you can see on that picture on this patient leg on the very right of the slide.
Yeah, so you could use serpiginous to describe the plaque on the right, but you could also describe it as geographic because it kind of looks like North America.
Bay Area.
Bay Area. And, the annular, people can have more than one thing. When you see annular lesions that have a scale like that, you absolutely must scrape it. The one on the left actually does represent a lymphoma, just so that you know that. But absolutely, as April said, doing a scraping for KOH is absolutely critical. Now, we also wanted to talk about the term lichenoid. So lichenoid can refer to what it looks like on the skin. So it looks like lichen planus on the skin, but it can also refer to what it looks like under the microscope. So we use it in both contexts, which can be kind of confusing, I think. So when I tell you, April, oh, there's polygonal plaques or polygonal papules on the wrist, for example, what do you feel like I'm describing to you when you hear that?
Absolutely, lichen planus.
Yeah. So it's when I say polygonal, it's almost like I'm telling her I think this is lichen planus because it has a sort of polygon-like shape, and also the color is really very purple.
There's a way to remember lichen planus, lichen purple planus.
Lichen purple
purple
planus.
color.
Yeah, especially in our darker skin types, lichen planus will be that purple color. And it can also have a little bit of a lacy look. And you can see the reason they called it lichen ages ago was because it can have that sort of lacy look like a lichen on the tree, for example. It's a white lacy color. Whereas the lichenoid infiltrate, that is going to be what it looks like under the microscope. So between the epidermis and the dermis, there's a ton of inflammatory cells hugging the epidermis. So that's what lichen planus looks like under the microscope. And so it's also important to describe particular features that you would see. So what would be some examples of features that would be really important to point out in the physical exam?
So this is a great example of vesicles. As the vesicles is less than 1 centimeter. There's like a fluency in there, like a little vesicles next to each other. The bullae or the pemphigoid picture here, more than 1 centimeter of that, and commonly found in patients who have bullous pemphigoid, which is an autoimmune disorder. And then the pustules or bacterial and fungal is a crassy lesion on the very right side of that slide.
Yeah. So both fungus can have pustules too, especially if it's going down the hair follicle on the legs. We call that Miyakis granuloma, and certainly with bacterial infection.
Yep.
So this picture on the right is actually a picture of a patient with pustular psoriasis of pregnancy. But as April was saying, the diagnostics are incredibly important. So you would definitely want to culture if you saw pustules and do a KOH if applicable. And then also for the vesicles, you can do a DFA or you can do a viral culture just to make sure you're not missing herpetic infection. When you see bullae, you definitely need to be biopsying for conditions like pemphigoid. And then the quality is also important to describe. So they can have what we call crusted erosions or excoriations from scratching. It can also appear like kinified, which is kind of thickened from rubbing when it's really itchy. There's a plaque of lichen simplex chronicus there too that you can see. And then there's the fissures. So what does it mean when you see the fissures in the skin? Like, what do you tell the patients?
So the way that we explain it is that we compare it to a skin. So to a tree branch or branch of a tree that is green. So when the tree branch is green, then the skin is soft and supple. So when you bend that branch, you won't see any cracks at all. But when the tree branch is brown, which is hard and dry, when you bend that branch, you will see a crack in it, which is like could create a fissure.
And they're so painful for the patients. So, so when we see that, we really want to talk about emoliation. So moisturizing the skin, we can use things like urea, 40% or 20% urea creams that are humectants that can bring the moisture into the skin and try to prevent that fissuring that occurs. And of course, we're going to be thinking about systemic agents when the eczema is very severe and fissuring. Now, what's interesting is that plaques can be raised, but they can also be atrophic. They can also be depressed. Okay. So when that happens, the dermis is affected. The dermis has been affected and damaged down below. And so what happens is at the top of the epidermis wrinkles like cigarette paper. So if I told April, oh, April, I have a patient with an atrophic plaque and cigarette paper wrinkling, what are you thinking when you hear that?
Prepare the biopsy and help stabilize that. Yeah.
Yeah, because that could definitely be lymphoma. And that's a case of lymphoma there on the left that, burn into your mind that cigarette paper wrinkling look. And then what about the right? If I said, I have papules coalescing into plaques and a confluent rash, then you looked at that, um, what would you think? Do you think that looks like atopic dermatitis?
Absolutely not.
Yeah, it does not look like atopic dermatitis.
No.
And why?
There's no eczematous way to look into it, and there's the papules that are separated and not in one area of the plaques.
Yeah, atopic dermatitis tends to affect areas that tend to be more dry. It's the center of the back. It has a different look to it. So this is a
Yeah.
case also of lymphoma, and so make sure that you're sort of burning these images into your mind about cases that would be really good to biopsy. Now, you can also have situations where the patient is just scratching themselves, right? And so if I say, there's no primary lesions, what does that mean to you?
It's a lot of times these patients comes in with excoriations, and then a lot of times the area that are spared is the one that you can't reach with your hands.
Mhm.
So that's what I define as like the secondary lesions.
Yeah, so if there isn't any primary papulous squamous or eczematous process, that's what provides an inflammatory cell infiltrate for us to use these therapeutics. So they may be scratching because they're very, very itchy, and you need to ask about their itch. And we're going to talk about that in great detail in our second webinar, especially, but you need to ask about itch. And also, sometimes they also can scratch out of nervous habit, and we call that neurotic excoriations. And we'll talk about how to manage those patients too. But you can describe them as linear or angulated erosions to imply that you feel that the patient is scratching and there isn't that much underlying inflammatory process that's present. And so, there are certain cases that understanding morphology can turn you into a superhero. And as a dermatology provider, you saved the day so easily just because you understood the morphology. So, what is a good example of that one, April?
Oh, we just had this case recently who had this young male patient who had coalescing confluent, as to say, rashes on his trunk and in his extremities that is crusting.
Yeah, and we refer to these as punched out erosions. So the patient had a history of eczema as a child and a little bit in his early 20s. He comes in and he has been given antibiotics, but what does he need in this situation?
Yeah, this is a case of our eczema herpeticum. So all he needs was the antiviral. So we put him on antiviral therapy, and that helped um with his condition. I think prior to that he was on a bunch of steroids,
Yeah, they give him
antibiotics,
antibiotics.
prednisone. Yeah.
But this is so classic. Just burn this picture into your skin for a really good example of what eczema herpeticum can look like. And with acyclovir or valacyclovir, it can do very well. Another way we can be superheroes is when we identify purpura. And sometimes purpura can be something that we see day in, day out, like actinic purpura, and other times it can be deeply concerning. And so we have to be able to distinguish those clinical situations. So if you take a glass slide and you push it down on a rash and it blanches, that's very common, right, in our rashes. But sometimes when we push it down, it does not blanch. And that means that the red blood cells have left the blood vessels and have extravasated, we call them extravasated red blood cells. So sometimes it's because the blood vessels are bursting, and that's why that happened. So what are some examples of how the blood vessels can burst and you can develop purpura?
Well, one of them is this creation from the scratching, as you can see on the first photo. The actinic purpura is the one where we're common in our elderlies, as they have this very fragile skin. So when it's just a little bit mild injured or something, they could get the purpura. And the other one is the pigmented purpuric dermatosis, or for that skin commonly found in their lower legs.
On the lower legs, yeah. So this is actually my ankle after I was running. Yes, I was a model. It doesn't look like that anymore. But so when I was running on the beach one time, I pulled my calf. So then the veins aren't going to work as well, right? Because I have an injury to the muscle. And so what happened was I went to Rome after, really hot in the middle of the summer, and I got a little bit of swelling in my ankles. Well, that little bit of swelling causes the capillaries to burst. Okay. So swelling in the lower ankles is very common because we have this very soft skin, both on our cheeks as well as our ankles. Now, giraffes in the wild, and I use this with my patients all the time to describe this, giraffes in the wild have leathery skin on their legs. It's really, really tight leather. And they have that. They've evolved over time to have that because they can't have swelling in their ankles. The veins have a long way to go. They can't have swelling in the ankles resulting in stasis dermatitis and ulcerations on their ankle, right? So they have to have thick, leathery skin to push that blood up, especially as they get older and the veins don't work as well. So how do we give our patients giraffe skin?
So there's a couple things. One is keeping the legs elevated, so the fluid doesn't pull down. One is the most important thing that we give is the Job's toes. This is the compression socks that we gave to our patient at 15 to 30 millimeter per mercury. And a lot of times you will hear this. It's so hard to put on. It's so hard. It's too tight. It is hard to put on, but it works. So we always tell the patient it works. And so the other also thing that we wanted to tell our patients is a low salt diet, so they can get that pulling edema help improved.
Because when you get this pigmented purpuric dermatosis for a long time, because the red blood cells have left, it deposits hemosiderin pigment. And so it's like iron branding your ankles. So in order to prevent this, wearing the Job support hose every day really does help a lot, and especially if you're on your feet. Now, warning needs to come into your head if you see the kind of retiform purpura that's pictured on the left. So that is a map-like purpura, and that is a sign that larger blood vessels are bursting. So it's definitely a situation that a biopsy would be needed, as well as extensive laboratory work. Or you can have a vasculitis where you feel across and the purpura is palpable. There's little tiny raised bumps. And so that's a sign of vasculitis. And if blood vessels are bursting in the legs like this, what other organs could they be bursting in?
Oh, very important to the brain, the kidneys, and the patient's lungs.
Yeah. So it would be important to do a urinalysis and to do blood work to make sure that, the other organ systems are not involved when you see palpable purpura. And then we have another way we can become a superhero yet again here. So this is the breast on the left of a woman and it has a sort of orange peel type look to it, right? We refer to this as peau d'orange in French. So it's an orange peel. And this is inflammatory carcinoma of the breast, or it is lymphoma. This particular patient did have lymphoma. But you can see when you get up really close that it's not just that the top layer of the skin, the epidermis, is involved with our spongiatic dermatitis, right? You can see how the dermis has been affected as well. And you can see that it's follicular based, right? You can see how it's based on the hair follicles. So this was a T-cell lymphoma that was follicular based. If you take a really good look at the morphology, you can see, and that would definitely need a biopsy. We also use the term woody induration to describe when the skin feels kind of firm, and it can have this champagne bottle look on the lower legs. What causes that champagne bottle look on our lower legs?
So what is the most common causes, what we discussed earlier about the stasis dermatitis, and when it's prolonged or chronic, it becomes what we call lipodermatosclerosis. As you can see, there's an example of that photo right there.
Yeah, lipo, the fat layer, dermato, the dermis, these are all layers that are affected with sclerosis or scarring process from that chronic stasis dermatitis. So lipodermatosclerosis is something we commonly see, and we need to try to avoid so that patients can continue to have a healthy dermis and subcutaneous fat layer. We can also refer to a plaque as sclerotic if it has more scarring in it, and that's definitely something that we need a biopsy if there wasn't a procedure there before. Then we have our apple jelly plaques on the face. And I remember being a resident thinking, that's not the color of apple jelly. Why do they keep calling it apple jelly plaques? But what happens is if you take a slide and you push down on the skin, it turns into that color. Okay, so this is a gentleman that was referred to us initially who was told that he had rosacea on his face. Now, if you have a golf ball sitting on your chin, and and you don't have involvement of the cheeks and nose, it's much, much less likely to be rosacea, right? So this is a patient that had lymphoma. You have to think about lymphoma and connective tissue disease like lupus if you have these thickened plaques with a lot of inflammatory cells. This person on the right had a bright red plaque on her nose. Now, the nose has tons of oil glands in it. So a patient with atopic dermatitis, that was the diagnosis that she was given, atopic dermatitis, is not going to have a lot of involvement of their nose where they have the most oil glands, right? It's going to affect other areas. So if Rudolph the red-nosed reindeer, bright red nose, you have to think about the possibility of lymphoma, and you have to think about connective tissue disease and do the labs and as applicable, do a biopsy. You want to try to focus on the temples or forehead if possible. Avoid biopsying the central face, but still do that biopsy and get the diagnosis for the patient. You had a patient like this fairly recently, right?
Yep, I just saw this patient on Friday, and she has chronic history of rosacea, where she has a redness on nose and the bilateral cheeks. She had this like 2.5 centimeter in duration, bright red edema. Well, as we talked about diagnostics, we have to run also a bacterial culture, making sure it's not a cellulitis. And also, in about a week or two or so, we would definitely consider doing a biopsy for this case.
Yeah. So we want to make sure we do our diagnostics. And here's an example of a gentleman that had full body erythroderma, and he has a darker skin type, but you can tell that even though his cheeks and elsewhere on his face, eyelids, everywhere was involved, his nose is spared. And that's very common with patients with classic atopic dermatitis. And then we have the erythrodermic patient, and we will talk about that subset of patient and how to manage that in subsequent webinars. But you refer to a full body eczematous eruption that is referred to as erythroderma, so inflammation of the whole skin. And, in our lighter skin types, it is easier to see the erythema, and you have this pinpoint crusts and the situation too from the patient scratching. But in our darker skin types, erythroderma can be just appear as hyperpigmented skin in the darker pigmented skin types. And so the patients that have darker skin types are at higher risk of being undertreated. Before this gentleman with severe atopic dermatitis came in, he was just given a 60-gram tube of triamcinolone. So when you're treating scabies and we give a 60-gram tube of permethrin, how many applications on the body is that?
So just 30 grams for the entire body.
So adult size body, 30 grams. So 60-gram tube is like for full body, it's like 2 applications, right?
Right.
So if you take a tub of moisturizer and you put in a 60-gram tube, you can apply it diffusely for, a few weeks, right? But atopic dermatitis is a disease of the whole skin. It's so important to use treatments that treat the whole skin when the whole skin is involved. This type of patient should not just be given a tube of triamcinolone every few months. He really needs to be given options. So you want to talk about the color when you're describing the plaques too. So we just talked about how they can be hyperpigmented. hypopigmented, and then also depigmented. So what is the difference between hypopigmented and depigmented in terms of when you see it clinically?
So for the hypopigmented, the skin color is lighter, so it's light. For the depigmented, there's absolutely absence of the pigment. But what about the dyspigmentation, the DYS?
So DYS, dyspigmentation, is just problems with the pigment. So it could apply to all of these. So hyperpigmented, hypopigmented, depigmented would all be considered dyspigmentation. And for the patient on the right, we think when we have a complete absence of pigment, we think about vitiligo. So you can take a woods lamp, and it's a purple color. You turn off the light and shine it, and it'll really make the depigmented areas more pronounced. So to be aware of that. And there's other colors that it could be too. So when we use the term erythematous, that could refer to a pink color or a red or bright red, versus the purple color you talked about earlier with our lichen planus.
Lichen planus.
And then when you say vivacious to me, I know you're trying to communicate something to me.
Oh, absolutely.
Yeah, when you say vivacious. So
Dr. Murase, we need to do a biopsy. That's what it means.
And labs for NA potentially, right? An anti-nuclear antibody. Because when April uses the term vivacious, like she used a couple of weeks ago, that is implying to me that it could be connective tissue disease. So this is a patient with subacute cutaneous lupus erythematosus. And it's really important if you see, burn this color into your head. This was a patient with type 3 skin, and this vivacious color is definitely something that needs a biopsy, probably for H&E and direct immunofluorescence. And we'll talk about the biopsies in the next webinars, how to distinguish between which to do. So then we have the borders. So you can describe the plaques as having well-defined borders or sharply marginated, or they can be more ill-defined. So that would be a way to describe the plaques. Sometimes you can describe them as having follicular accentuation, and you can see for this picture on the left, this is these plaques that are coalescing, these papules that are coalescing to plaques, they have a very follicular centered look to them, right? So this actually is a case of lymphoma here on the left, and it's almost like it's going in and out, right? You can see the bright red, and it's sort of a lighter pink in sort of different stages. This would definitely be something that you would want to biopsy, because it was a follicular centered T-cell lymphoma. Now, on the right, we also use the term follicular-based, or we can say acneiform. So follicular-based papules or acneiform, papules kind of have a different, it's a different description than follicular accentuation of a plaque. And what does it mean to you when you see desquamation?
So desquamation is one of the things that we see with patients who had less inflamed. Mm-hmm. And also the skin is peeling off as it's healing.
Yeah, so it was really, really red. It was really, really inflamed and horrible at one point, but now it's on the way out. So then the skin kind of peels, and it's sort of almost like a snake skin coming out when it desquamates. Also, we can see plaques on the face that ulcerate. And when you think about ulceration, what are the kinds of things you think about in that situation?
Diagnostics again. So here we go again with the diagnostics, really important for ulcerated plaques. You want to know, of course, rule out skin cancers and other condition.
Yeah, so this was a lymphoma, so the biopsy was the thing that saved the day, but certainly doing a culture, a bacterial culture or potentially a fungal culture, depending, would be appropriate thing to think about doing. And then we can describe the scale of the rashes. So it can be a very light, fine scale that we refer to as pityriaciform, a pityriaciform scale. What are some conditions that have a pityriaciform scale?
From it's related to Rice's rosea.
Yeah, pityriasis rosea or tinea versicolor could have that light scale.
Scales, yeah.
Whereas the term psoriasiform, there can be different. So it just means like psoriasis, right? So psoriasis can look like these hyperkeratotic, thick plaques, very common to fissure, right? Or the psoriasiform scale can present as what we could describe as micaceous or silvery or lamellated scale. And that's because the light hits it and it turns it white, because there's air there's air in the scale. So that's why it has that white color to it. And we can describe a trailing scale. And so, in the situation on the left, when we have the part, as you were saying, sort of the desquamating part that's sort of all done, and then there's the active border. So you're definitely going to want to do the KOH.
Absolutely.
What about the term retention hyperkeratosis? What does that mean?
It's like a very crusty lesion on the patient, as you can see on the scalp. So reductive hyperkeratosis is basically a crusty lesions that is the patient that is just not absolutely does not washed or like removed. So it's continue to like overlap those plaques on this on the scalp.
Build up. So even if you just soak it in water and then just gently remove the crust with baby oil, then you can see the underlying condition that's below that. Biopsying crust, there's no inflammatory cell infiltrate. There's nothing useful for the dermatopathologist. You have to get under that crust and biopsy below to give them the information they need. And this picture, just so that you know, on the right is erosive pustular dermatosis of the scalp, which is when you can get pustules and neutrophils that come together and create these plaques. So this is not cancer, and it's not an infection, but I still think it's very reasonable to do a biopsy in that situation to make sure you're not missing cancer. Okay, so what about a plate-like scale versus an ichthyotic scale?
So we remember the dried crack that looks like a riverbed of the dry cracked skin. These are very common for patients who have steatotic eczema.
Yeah, we see it all the time.
We see it all the time, and in comparison to the other ichthyotic scale, or what we call a fish scale, when you see these patients with that skin, you will think this patient has a very severe cirrhosis.
Yeah. So the ichthyosis is more of a genetic condition, whereas steatotic eczema, the dried skin eczema, is so common on the lower legs, and it can just be needing to put like a really thick moisturizer, because moisturizers come in 3 strengths: lotions, creams, and ointments. So putting a thicker ointment on the front of the legs, like Aquaphor, for example, can be helpful. And then we describe the distribution. So they can be diffusely scattered. We use that term a lot, right? Diffusely scattered papules, or widely distributed papules and plaques, numerous, because writing those things in the dermatopathology report for the dermatopathologist can be really helpful, because they need to see what you're seeing. If you don't describe the rash in your pathology report, it's kind of like garbage in, garbage out. They don't know how to interpret. But if you describe it effectively for the dermatopathologist, it really helps them. And then that can be the papules and plaques can be accentuated in certain areas. That's another term we use. So what about if it's accentuated on the waistline, like this picture shows?
This is one of the very common we see. It looks like allergic contact dermatitis. It's localized on the waistline for this patient.
Yeah. So this actually was allergic contact dermatitis. They had melamine formaldehyde allergy to the uniform that they were using at work, and he would tuck in his uniform, and it was accentuated. And when we had him stop the uniform and we found that allergy on patch testing, he did extremely well. What if I tell you that there's some papulosquamous papules on the wrists?
So there's 2 things that comes into my mind here looking at that photo. One is it has psoriasis form, so it's like psoriasis, but also remember the lichen planus, lichen purple planus. There's a polygonal shape there and a purplish color. So I would definitely consider the lichen planus on that hand.
It is psoriasis, but you're absolutely right. Those 2 are what's on the differential. What about if you say eczematous plaques accentuated on the antecubital fossa and the popliteal fossa? What condition are you thinking in that situation?
That's absolutely a very classic presentation of atopic dermatitis. This is what we call eczema.
Yeah. And the papules can be agminated. You can describe them as agminated papules, clustered vesicles, or agminated vesicles, or it can be a photo-distributed distribution. So that's when the light hits on the malar cheeks and you get the V of the neck, but where's the sparing? Hint, hint.
Hint.
Right here.
Hidden. Not here, not being exposed to sun.
Right, the place that's not exposed to sun. So that gives you a hint that you could be a photo-distributed rash, which is common in connective tissue disease. Now, what are some classic ways that we think about psoriasis? And this is the kind of thing where some read the textbook and others do not read the textbook.
So this is a very classic textbook that psoriasis is commonly found on the scalp, on the elbows, and the lateral knees. However, it's really important to look for other areas to look for psoriasis: the sideburn, the nails, the umbilicus, and the gluteal cleft.
The gluteal cleft. One of the first questions that April and I want to ask when we go in the room when we're trying to decide, is this psoriasis or eczema? I say, can we look at the top of your gluteal cleft? Because gluteal pinking is pathognomonic for psoriasis.
And we're wearing pink today.
Yes, so that everybody will remember the gluteal pinking, because it really does help you to distinguish. And then also the oil spots on the fingernails or the nail pitting is also classic. So looking at the nails is a really good thing to do for our psoriasis patients. And then what do we do for our atopic dermatitis patients?
So we look for what we call the palmar hyperlinearity.
Comparing our palms
Comparing
to
our
our
palms.
patient.
So just remember, if you have too many lines, then that's your atopic dermatitis hand.
Yeah. So that means that you have a filaggrin mutation, and filaggrin is the thing that cross-links the stratum corneum and keeps that skin barrier very strong, the oil layer on the surface of the skin. And we have the ever so important, one time it's very important to ask about family history for melanoma, and it's important to ask for family history of the atopic triad if you're trying to figure out if it's atopic dermatitis. So what is our triad here?
So at the top is atopic asthma, childhood dermatitis, atopic dermatitis, and the allergic rhinitis. So a lot of times patients who have one of this condition could have 2 of 3 or 3 out of 3.
And in our area, in the Bay Area, they could have grown up in a more humid climate, like the Philippines or Taiwan, or different areas of India that are more humid. And then they move to the more arid climate of Northern California, and they're developing eczema for the first time. But in childhood, they probably would have had eczema if they weren't in such a humid climate. So, and what is the thing that they always say, the atopic patients all the time?
I feel like I'm allergic to my sweat. Every time I do my exercise, if I sweat, I flare up with these rashes and it's itchy. So that's most common.
It's like pathognomonic. I feel like I'm allergic to my own sweat. And you can see in the picture, there's little Denny Morgan lines right underneath the eyes. There's venous congestion, making it look kind of a bluish color. So it looks like somebody was kind of socked in the face, right? Or there's a lichenification under the nose from rubbing from the allergic rhinitis. And so that creates what's called the atopic facies, which are features that kind of make the patient look like they may have atopic dermatitis. And we already talked about antecubital fossa, popliteal fossa, and definitely the neck also as a site. It's very common. And what about if we put a patient on an agent that's suppressing the Th2 arm, but they still have residual in certain areas? What other diagnoses do you think about?
Yeah, we're going back again to diagnostics, right? So we explore and make sure that we rule out allergic contact dermatitis, because these allergic contact dermatitis are very common on the eyelids and the face and the hands and the perianal or genital area.
Yeah, so those are the top 3. Perianal, genital, hands, and eyelids and face. So if they clear everywhere, but that's the area that's residual, you have to think about that. Okay, so for our last case, we're going to practice a little bit here with using the terms so that we talk like a dermatologist. So this patient came to us maybe 2 years ago now.
Yeah.
Atopic dermatitis that had failed dupilumab. Okay, so April, how would you describe what you're seeing in this patient?
This patient has a widely distributed pruritic papules because she's very, very itchy on her trunk and her extremities.
And they're just all over, covering
including the face. I remember she has one on the face too.
Yeah. And what do you think about those papules around the areola?
So around the areola, you can see it's like bright red and juicy, and it's the perfect place to do the scraping for the mites.
Yeah, those papules by the areola are so juicy is a great word for it. So there are certain places that are so important to learn how to scrape. And the best place to scrape is you take the foot and you look on both sides of the foot really carefully. And you'll see this tiny little line, this like 3 to 5 millimeter tiny thin line. You can see a burrow there on the cheek too in an elderly patient. So you take your blade, you just go right over it, and it's almost like you're writing with a red pen, 3 to 5 millimeter when you just take it, and that's going to get your positive. Scabies, and of course, now the papules here, do you think that they're coalescing into plaques?
No.
And they do in atopic dermatitis. So the fact that these is their individual papules is really important to note on the physical exam. Scabies in the elderly is more common on the face and the scalp, and you can actually get complete sparing of the finger webs. So this was a case of Norwegian scabies, tons and tons of mites on this poor person that was suffering for 4 years. And so you need to make sure that the permethrin is applied to the hairline, scalp, neck, temples, cheeks, and forehead. And most importantly, do not undertreat. These patients can, I mean, the person that we just showed you, she had been treated with permethrin once or twice before, and she suffered so much longer than she needed to. So it's I plus P, ivermectin 0.2 milligram per kilogram and permethrin, a week later permethrin, and then a week later ivermectin and permethrin. And I've only seen 2 patients in 18 years fail this, so this is a good treatment to start with. So our goals for the next 3 months, and we're happy to take questions very shortly, but we just wanted to encourage you to try to use the type 1 versus type 4 hypersensitivity framework when you're talking to your patients. Talk about the difference between the eczematous and the papulosquamous rash and why a biopsy could be helpful in distinguishing those. Practice using the terms to describe the distribution and like the quantity, quality, color, scale of the dermatitis when you're writing your histopathology forms and you're presenting to other colleagues and attendings. And then also look for the key findings in morphology so that you too can be the superhero. Joe, are you there?
Absolutely. I was just digesting all this information. It was fantastic. So we've got one burning question. I know all of our attendees are itching to get their questions in, so we're collecting them through the chat as we speak. One of the questions was about lymphoma, and there was a comment that thank you for reminding us all to always think about lymphoma. And they asked what type of biopsy on the face would be best to make the diagnosis if you have a juicy lesion and want to rule out lymphoma.
It's really that's a great question, first of all. And so I do both a flow cytometry blood test. So I'll do a leukemia lymphoma blood test, and in addition, of course, doing the biopsy. So if it's elsewhere and not on the face, we probably want to do about, a 5 millimeter just to make sure that we're getting plenty of tissue as a punch, right? And so the face, the issue is going to be that if you biopsy this area right here, that tends to scar more, and also the central nose. So if we were can we actually go back to the picture that has the apple jelly, if you don't mind the person running the slides? The ideal place would be to try to do a 3 millimeter, perhaps 4, depending on what it looks like on the sides, like preferably the temples or the sides. The preauricular cheek heals beautifully, or the forehead if needs to be. And I would prioritize that over the central face if at all possible, but definitely punch biopsies and not beautiful. Thank you. So for example, I think you can see Joe, can you see our pointer? No.
I'm not.
So I would be prioritizing the lesions that are high up on the forehead and particularly over to the sides if possible on these patients. For the patient that had the rosacea, because he had a
I'm
biopsy.
circling this juicy lesion on the cheek,
Yeah,
and then
yeah.
these
So
are the higher ones on the forehead that you'd prioritize.
yes. And the juicy one on the cheek, I ended up having to do actually a larger biopsy because the previous dermatologist, who's an excellent dermatologist in our group, she had biopsied and done a 3 millimeter and got the rosacea. And I looked at that and said, that's not rosacea. So I did a 5 millimeter and I got the answer. So, when in doubt, the clinician always wins. If you get a biopsy back and it doesn't make sense to you, do it again. So you win. The clinician always wins. If you get biopsy backs that don't make sense, just you have to question them.
Yeah, and I think the size of this lesion on the chin, if you didn't want to do a large 5, you could do multiple smaller ones,
Mhm.
um, getting some of the active border and then some of the action in the middle, getting different sites of the same lesion will give you a better chance at getting
Yeah,
the
I love that
actual
idea.
diagnosis.
Mhm.
I'm gonna read another question here. We're running up against on time, but one of the we have questions also about the regimen, which we will post for ivermectin and permethrin, followed a week after by permethrin, and then a week after with ivermectin and permethrin. So we'll get that mnemonic going and remind everyone of that. But the next
It's
question.
published. Oh, it's published in the International Journal of Women's Dermatology. So if they type in my last name, Murase, and scabies into Google, they'll be able to find it because it's online open access and they
Oh,
can read the paper.
perfect. We'll make
I
sure
did
that
that when I was
resource is
editor in
available.
chief of the journal. Yeah.
Oh, excellent. And that was really helpful. So the patient says, or the question is, I was curious, does the itch intensity primarily correlate with the severity of inflammation and a patient's personal threshold for itch and pain? Or are there other factors at play, such as specific body areas?
I love that question. I love that question because I can tell you, and we'll talk about this in the second webinar we do. Some of the patients that come in that are the most miserable and are using our tissue box and are so desperate had very little to see on their skin. So you really do have to separate in your mind because as dermatology providers, we are so visual and we look at how red the skin and how inflamed it is. But the patient's experience is with the itch and with the pain. That's the thing that they care about. So it's so important in that intake to make sure that you're assessing the itch and assessing the pain because both of those are invisible. And so as providers, we need, because you're right with the person that was asking the question. Sometimes there can be very little to see, but the patient is incredibly affected by the level of itch due to the inflammatory process that's not as apparent.
Yeah, I think that quantifying um, through subjective questions from and measurements from the patient, the level of miserableness that they're experiencing in their life, uh, specifically with respect to itch and with respect to pain, are going to be paramount to us making sure we make the proper intervention for these patients. And so, with that, we're going to move on to our next slide. And I want to thank Dr. Murase and April for this comprehensive delineation of morphology and distribution of the lesions and helping us put the picture together in terms of how the immune system plays a role with systemic inflammation driving disease. And for us also to continue to ask questions to make sure we're not missing things like lymphoma or scabies. So the itch and rash whisperers have spoken. We could not be more appreciative for your clinical insights and teachings tonight, and we look forward to your participation and next webinar, which will bring us more specific pathophysiology and therapeutic agents to actually target and treat the diseases that we see commonly in the office. And Sanofi and Regeneron, AbbVie, our sponsors for tonight, providing the support for nurse practitioners, physician assistants in recognition of their role in dermatology in collaboration with our dermatologist colleagues. We could not be more thankful for your support. So thank you.
Thank you for having us. We really hope as providers that this is helpful to you. April and I really want to be a resource for you all, that all of you that came in to listen tonight.
Thank you.